So good morning, everybody. So today we're going to talk about ONAPGO, which is one of the new subcutaneous pumps that's available in the US. So we're quite excited that we have two pumps. And of course, apomorphine pump has been available in Europe for over 30 years. So we're just catching up with them. So apomorphine is an infusion that's for patients who are currently already on levodopa and who are having motor fluctuation. So anybody who takes Sinemet or carbidopa levodopa more than 4 times a day would be eligible for the pump. And then there's some feedback here, but maybe if I stand over here. So apomorphine is not to be used with Zofran or ondansetron or patients who are allergic to sulfites or have a history of asthma. So we're going to talk about levodopa and why you get off times in Parkinson's disease and how levodopa contributes to that, why your off times disrupt your day, and how ONAPGO can improve your good on time. So is there any way that there's sort of a little bit of feedback in the computer? Let's see. Yeah, I think, well, no, it's still talking back to me. Yeah, it should be muted.
Well, you're muted, but it's also can be,
Yeah.
yes, your volume came back up.
Oh, okay. Uh-huh.
There you go.
Okay. So that's that. Okay. So what happens in Parkinson's disease? By the time you come and see us in the neurology clinic with your motor symptoms of PD, what we use to diagnose Parkinson's disease, that's the tremor. Although 50% of patients never develop that classic resting tremor, so not everybody has that classic resting tremor. Slowness or stiffness, that bradykinesia, it's the reason why your doctor has you go like this and tap your feet. And trouble with gait and balance, 60% of those cells that produce dopamine have already died off. So you've already had Parkinson's for about 10 or 15 years before you actually see a neurologist. And that's your history of constipation, anxiety, depression, losing your sense of smell, and REM sleep behavior disorder, where you're acting out your dreams, that you're talking and screaming and kicking and punching in your dreams. And that many times happen many years and sometimes decades before your diagnosis of Parkinson's disease. So you're coming in, 60% of those cells have already died off, and you've got 40% of those cells still living, producing dopamine. So it's the reason why you can get by taking Sinemet, your yellow carbidopa levodopa tablet that basically only has a 90-minute half-life. And the doctor prescribes it to you 1 tablet 3 times a day, and you can eat a cheeseburger and forget the noon dose, and you don't really notice any problems the first 5 years of the diagnosis. But as the disease progresses and you continue to lose those dopamine producing cells, and more of the dopamine is coming from the pill, then you do notice, does that pill have a 90-minute half-life or a 4-hour half-life like Crexont or Rytary? So you notice that the pill doesn't last as long. So the levodopa half-life, has a big difference on whether you have those off symptoms. So your most common off is end of dose wearing off, where you take the medicine 3 times a day, it lasts 4 or 5 hours, but then as the disease progresses, it lasts less and less time. And you notice 30 minutes, 40 minutes, an hour before your next dose, the tremor comes back, the stiffness comes back. And so we either take it closer together or increase the dose of the medication. And remember, so that's one reason why you develop off periods. And then the other reason is that you have bradykinesia, or slowness of movement, and that impacts all of the muscles of the body, including the muscles of the gut. Because the gut moves slower, the more fluid gets sucked out of the stool, and the stool gets harder, and you get constipated. So that's why PD patients have constipation. And once you're constipated, that gastrocolic reflex stops working. So usually you eat lunch and you're swallowing it, it goes all into the stomach, and the stomach starts to digest it and then sends a message to the colon and says, hey, I'm digesting this food. I'm going to push it forward into the small intestine where it's actually going to get absorbed. But if the colon sends back a message and says, you know what, I haven't had a bowel movement in 3 days, then everything stops. And so you notice that as a delayed on or gastroparesis. So the patient has a slowed gut. And so that usually you take your pill and it kicks in 30 minutes, but 7, 8 years into the disease, you take your pill and it might take 2 hours or maybe not work at all because of that delayed on or that slowed gut. So it's 2 reasons why levodopa we have trouble with levodopa, and it contributes to the off periods in Parkinson's disease. So if we could have a medicine like apomorphine that's subcutaneous, we bypass the gut. So it doesn't matter what's going on in the gut, if you're constipated or not, if you ate lunch or not, if you had protein or not, because protein uses the same transporter. Think of it as the same little elevator from the stomach to the brain to take your levodopa. And that's why you notice the competition between protein and your levodopa. So apomorphine doesn't use that elevator. It has its direct shot into the brain. And so that's why you notice that there's different ways of why that levodopa doesn't work quite as well after the 5th, 6th years of your diagnosis. So anybody have any questions about that? Does that make sense? Sort of the barriers of, and then does anybody know of that yellow Sinemet that you guys are taking? How much of that levodopa is actually making it from the stomach into the brain? Does anybody know? It's less than 5%. It's almost nothing. So we need lots of help to get all that levodopa into the brain. And if we can use a medicine that doesn't need to use the little elevator and get chewed up by 2 enzymes, then we're better off. And so it's one of the reasons why we would look at apomorphine as one of those drugs. And so it's the reason why levodopa is not as reliable as the disease progresses, because it has a very short half-life. And then, it has these problems with the gut and the little transporter. And then the other thing that happens is that levodopa is a prodrug. We can't give you dopamine because dopamine doesn't cross the blood-brain barrier. So we have to give it as a prodrug, levodopa. But levodopa has to be turned into dopamine in the brain in that presynaptic neuron, the one that makes the dopamine. But we said that by the time you come into the neurologist office, you've already lost 60% of those cells. So as the disease progresses, there's less of those cells to turn levodopa into dopamine. So we have less of that buffering capacity and less of the capacity to change that levodopa into dopamine. So if we can bypass that and use a drug that's not a prodrug like apomorphine, then we're better off. And so what happens in the past, what would we do? When you had end of dose wearing off, we would either take the medicine closer together, or we would increase your dose of medicine. You do instead of 1 tablet, you take 1.5 tablets or 2 tablets 3 times a day, or we would add in other medicines that would make your levodopa last longer. So medicines like opicapone or Ongentys that blocks COMT and makes it last longer, and MAOB inhibitors like Azilect or Rosagiline, or other dopamine agonists like Nupro or Pramipexole or Mirapex. So there's different strategies, but we were always sort of stuck using this levodopa that was very short acting and taking multiple doses during the day. And we know with each dose of levodopa that your on time is just that little on time between doses. And so that if we're taking it every 3 hours, we're not getting more than 3 hours of on time. So it's the reason why your doctor would go to longer acting forms of levodopa like Rytary or Crexont and use once a day medicines like Gocovri or once a day of your agonist or MAOB inhibitors, so that we only had to migrate that pill from the stomach into the small intestine once a day instead of multiple times a day. And then now that we can bypass the gut, then we're better off. So we know that about 90% of patients have motor fluctuations by the end of 10 years. And those motor fluctuations is what causes the disability in Parkinson's disease. And of those motor fluctuations, it's usually the off periods that causes more disability or more disabling to the patient. The patient prefers to have some movement, even if they're a little bit of dyskinetic, but they're moving around. It's easier to get in and out of the chair. But if you're off, it's hard to button a shirt, it's hard to swallow, it's hard to speak. And not only do you have your motor symptoms of PD, where it's hard to get in and out of a chair, but you have non-motor symptoms of Parkinson's. So just like you have the bradykinesia, slowness of movement, you can have bradyphrenia, slowness of thinking. So those off periods are disabling for the patient and cause the patient to require more help from the caregiver, the family unit, to help them with dressing, bathing, and activities of daily living. So here we can see a patient who's off, so it's hard for him to get in and out of the chair. You see that we call that an in-block turn. So it's hard to make the turn. It's hard to walk to the other chair, and he'll sort of plop down when he sits down. And so, those off periods can lead to falls and lots of other disabilities. So we talked about the end of dose wearing off. That's the most common, off period. Then there's the delayed on, because you have that gastroparesis or that slowed gut. Then there's morning off where you're taking medications throughout the day and you're sort of filling up the gas tank throughout the day. But then at night you go to sleep and you don't take any medicine, you wake up off. That's called morning off or morning akinesia. So it's the most common reason for using on-demand therapy like Ambrosia or Apokyn to get you started with your first dose of levodopa. And then there's unpredictable offs. So think of your levodopa like gas in the car. So if you're driving your car at 80 miles an hour, it's going to use up more gas than if you drive at 50 miles an hour. And that's why you notice that every day is different in Parkinson's disease. And that some days my medicines last longer than others because it depends on what I'm doing that day, both physically and emotionally. How fast am I going to run through that levodopa? So that's the unpredictable off. So again, you want to use once a day medicines or have on-demand therapy to rescue you from the doses. So we can see, here's a patient on the top that his day sort of punctuated by these off periods. And so he has very little sort of green time. And what we want is to give you more continuous on time. So on time that's not punctuated by off periods so that your day is more predictable. So we know that when a patient comes into the office and says, gosh, I never know when my pill is going to kick in and how long it's going to last, that's a pump patient. And that means that the gut's not working and my dose of levodopa is not long enough to get that patient on during the day. And we know that once you start to plan your day around every single dose of levodopa, you stop doing stuff. And we don't want that. We want you to wake up during the day and then plan your day, not think about Parkinson's disease. And we want to divorce you from the 6 alarms on your phone and then just, just live your day and not punctuated by all of these alarms and these off periods. So the sound should be playing. Where's the AV guy?
My name or sewing. Even walking would become more difficult. I was taking a lot of pills a day. The carbidopa, levodopa every 2.5 hours, and a ropinirole every night. After about 10 years, the oral medications became less effective, so it started to become harder doing things on my own.
So there we see that, she's taking medicines sort of every 2.5 hours. And she's saying, it's hard to me doing things by myself. And so again, she has probably 8 alarms on her phone. We want to divorce her from the 8 alarms and we want to get to you more continuous on time. So more predictability in her day so she can do the stuff that she wants to do without always having her spouse, her family helping her with activities of daily living like dressing and bathing. So in the past, we would increase your dose of levodopa, increase the number of times that you take the levodopa during the day, use longer acting forms of levodopa like Rytary or Crexont, add in more medicine. So we'd go into polypharmacy and you'd be on 3 or 4 different agents to treat your Parkinson's disease. And so what patients would stagger their meal time, so trying to avoid that protein so they don't have such a deep trough or just using their protein just at night and not during the day, or taking their medications around, with an empty stomach, or waking up early. So many times before we had on-demand therapy, patients would wake up, take their dose of Sinemet, and then go back to sleep and then wake up 2 hours later. So today we have on-demand therapy where you can take your Crexont and Ambrosia or Apokyn at the same time and get started, or use a pump and not be off when you wake up. So we've got many new medicines. And so now that we have all of these new medicines, I encourage you to come into your doctor's office and don't be the nice Parkinson's patients that you have always been and say, we ask you, how are you doing? And you're like, I'm good, I'm fine. Be more like a migraine patient and complain and say, I could be better. There are things that I want to do that I can no longer do. And let me try these new medicines. Because we're still 90% of our PD patients are on medicine Sinemet that came out 50 years ago with the moon landing. But there's all this new stuff that works really, really well. But we're very conservative as doctors. And in Parkinson's disease, because your medications, although they make your motor symptoms of PD better, like tremor and rigidity, gait and balance, it makes your non-motor symptoms of PD worse. So I increase your medicines and I can make you more orthostatic or lower your blood pressure, and that can cause falls. I can make you more nauseous. I can make you confused. I can make you hallucinate. I can make you compulsive or a gambler. So if you walk into the office and I see that you have a tremor and I ask you about it and you say it doesn't really bother you and you're good on your medicine, I'm not going to change it. But if you tell me, yeah, this tremor is bothering me, I can't do my knitting, I can't do my woodworking, I have trouble cutting a steak, then I'm going to push the medicine. And if we get some low blood pressure, some hallucinations, then we can treat them. But because you're telling me this is bothering me enough to do it, then I'm going to do it. But otherwise, I'm going to be like, oh, if it's not broken, don't fix it. So, but now that we have such good medicines, come in and complain because we can fix it now. And we can do a really good job with the new medications that we have. But remember, your doctor's very conservative and the patient's very nice. So Crexont is a long-acting levodopa. Yeah, so Crexont is a capsule of carbidopa-levodopa, and your levodopa comes in little microbeads and pellets that adhere to the jejunum, the small intestine, that absorb over time. So whereas the tablets of Sinemet, the carbidopa-levodopa, or Rytary, which still is a capsule and has microbeads, but it doesn't have the pellets that stick to the jejunum, those just kind of bypass, they just run through your GI system and they don't stick to it. Whereas Crexont is better than Rytary in the sense that it sticks to the small intestine and absorbs over time. So you get more on time per dose. So it's the only way with oral medications that you can approximate getting you like a pump without using a pump. So we're going to use Crexont 4 times a day before we're going to go to a pump in a patient. Yeah, so then they can adjust the dose so that you have a little bit extra medicine, a little bit more gas in the tank in the afternoon. So we'll talk about apomorphine or Napco, which is an apomorphine infusion. So for patients that have been on Crexont or long-acting levodopa 4 times a day and you're still having off periods, and so instead of going to a 5th, 6th dose and polypharmacy, taking multiple agents for Parkinson's disease, we would consider a pump in those patients. So a Napco gives you a continuous form of apomorphine, and we'll talk about what apomorphine is, a dopamine agonist. And that's what it looks like. And it's about the size of an iPhone 15. And so it gives you more reliable dosing. So it's bypassing the gut. So it doesn't matter what you ate, when you ate, if there's protein there or not. It doesn't matter because it's going subcutaneous. So it has a good absorption. And it's consistent. So it doesn't fluctuate, it doesn't peak and trough with each dose of the oral medication. You start the dose and then it's continuous until you turn off the pump. So we avoid these peaks and troughs in patients who are taking oral medications. So those are the pluses of being on. And so let's talk about, so we talked about the different kinds of offs. Let's talk about how a pump helps us overcome those off periods. So end of dose wearing off, where the medicine wears off between doses. If you're on a pump, it's continuous. There's no wearing off because it's not peaking and troughing. If you have delayed on because you have gastroparesis or constipation, the pumps are subcutaneous. So I'm bypassing the gut. That's not working in Parkinson's disease. So it doesn't matter what you ate or when you ate it if you're on a pump. If you have unpredictable off, so you went to rock steady boxing or physical therapy, or you had to see the accountant and pay more taxes and that stressed you out, the pumps have an extra dose button. So you just press the extra dose and give yourself a little extra dose like in the afternoon if you need to fill up that gas tank again. So it gives you that, it has on-demand therapy already built into the pump instead of having to carry your Inbrija or your Apokyn around. And the morning off, you can run your pump 24 hours, although apomorphine in the US is approved for 16 hours, so daytime use, so that you don't wake up off or have morning akinesia. So the pumps can overcome a lot of the off periods that we get with oral medications. Yes.
Basically a shot, or is it installed in your body.
So this is what it looks like. So here's the pump, and then this is how it's quote unquote installed in your body. So it comes as a little vial. So this vial doesn't need to be refrigerated. You just keep it at room temperature, and you don't need to draw it up into a syringe or anything. You just put the vial into the sleeve, and then you connect the sleeve into the pump. And then do we have a pump here that they can see or no? Oh, okay. And then we can pass it around so they can see it. So then you can just install the cartridge into the pump, and then you apply what we call this a cannula. So this is a little subcutaneous cannula that goes into the skin. So it's just like a type 1 diabetic pump. And then you just move this cannula every day so that it doesn't, that part of the body, that skin doesn't get red or infected. And then you connect it with the little tube. And that's how it infuses into the skin. So it's not, unlike our old pump, Duopa, which needed a PEG-J, a tube that went into the stomach, there's no surgical procedure. It's subcutaneous, and you just peel it off every day. So if you wanted to try it, it's very easy to try it. And if you didn't like it, then you just peel it off and go back to your Crexont or Rytary. So it's not like DBS or the Duopa pump that there's some surgical intervention that we have to do to start the therapy. So this is much easier. So what questions? Does that make sense? Yeah. Mm-hmm. Yeah. Yeah. So levodopa turns into dopamine in the brain. So razagiline is an MAOB inhibitor. It inhibits dopamine, the metabolism of dopamine once it gets into the brain. A dopamine agonist, like apomorphine, it goes in, it sits on the same receptors as dopamine, but chemically it's not the same chemical. And to get to those receptors, it doesn't get chewed up by two enzymes like levodopa does, and it doesn't need to be converted into dopamine like levodopa does. It just goes straight through. So there's a lot less barriers to getting that apomorphine or a dopamine agonist into the brain than there is for levodopa. Mm-hmm. So levodopa has always been thought of as the gold standard because that's what we've had for 50 years. But apomorphine gives you continuous dopamine tone, which is what we want without a lot of the problems of levodopa. Yeah. Right. Mm-hmm. Yeah, so it's apomorphine, but apo means without morphine. So it's a derivative of morphine, but they've taken the opioid part out. But it looks chemically very similar to dopamine, and that's why it can go and sit on the same receptors, and it's more balanced, unlike your oral dopamine agonist, which give us a lot of trouble with swelling in the legs and compulsive behavior and hallucinations, because apomorphine is D1, D2 family. It sort of is more balanced like levodopa. So although you can see those side effects, they're a lot less than, let's say, an oral form of an agonist like pramipexole or ropinirole. So, but that's why it has apomorphine without the morphine. Yeah. And you would think, oh, it's a morphine, I don't want to do anything about it. Yeah, but apo means without. Yeah, yeah. So that means we just have to educate the patients and the doctors. So off periods? Yes. Yeah. So if you're taking oral medicines more than 4 times a day, that's a pump patient. Mm-hmm. So think of it like a type 1 diabetic patient. So today we never use sliding scale insulin on a type 1 diabetic, which is what Sinemet is, but we do that all of the time because we're still using this medicine that came out with the moon landing and Parkinson's disease. So now it's 2025, we've got these new medicines, we need to move forward and use better medicines. So if we maxed out your Crexont, so you're on 2 tablets 4 times a day, yeah, and then we're going to have to go to a 5th dose of medicine or add in more adjuncts to get the job done, then I would consider a subcutaneous pump in that patient. Mm-hmm. But before that, because this is going through the skin, So remember, this is going through the skin. And so some people will have an allergic reaction in the skin. You know, you do have to put that thing together every morning. So it's much easier to pop a pill. So if I can get the job done just popping 4 pills a day, I'm going to do that. But once it's more than 4 pills a day, then the benefits outweigh the side effects or the risks of using a pump. I'm going to use that because I'm going to get more continuous on. And remember, what I want to give the patient is more predictability in their day. I don't want them to be planning their day around every single dose of levodopa. I want them to start their therapy and start their day, not worry about their Parkinson's disease. And so that's why I would consider a pump in those patients. Mhm. Yeah. So you can go up to 350 milligrams of Crexont. So if you're on 350, two capsules 4 times a day, then you would be a pump patient. Mhm. Yeah, so it comes, those are the orange pills. Yeah. Mhm. Yeah, so the nice thing about the pump, so unlike the oral medicines, although this year in 2025, your Part D is capped at $2,000. So it makes it much easier for us to be able to use multiple branded medicines in Parkinson's today. Your pumps, like DBS, comes out of Medicare A and B, not your Part D. So there's no copay for the patient once we get it approved by Medicare. So that's nice. It doesn't come out of your Part D. Uh-huh. So that makes it a lot easier. I mean, the number one barrier for us treating Parkinson's disease is that patient can't afford the therapy, that they can't afford Crexont or Gocovri or Inbrija. And so in the past, we were stuck with our, Sinemet because the patient couldn't afford anything else. Mhm. So today, the pumps out of Medicare A and B makes it a lot easier for us. We just need to do the prior auth and get it approved by Medicare. Yep, you carry that either in a pocket or a little sling and you carry it with you. Mhm. So in the US, it's only approved for 16 hours. So you would take it off at night and then either use a dose of Crexont or you may not need any medicines and then start it off in the morning. Mhm. What else? Uh-huh. Yeah, so the VA, it would be approved. Are you guys approved by the VA yet or not? I mean, or it's in the process. Yeah. So, I mean, eventually it will be approved by the VA, just like Duopa is. Mhm. So it's just a matter of doing the paperwork. Yep. So you can put this over here, the thighs, the flank, and the arms. So you can move it around. So we just want you to move it around every day so that the same part of the skin doesn't get red and irritated and it doesn't cause an infection. Mm-hmm. Yep. It's just sulfites. It's more the sulfites than the asthma. Mm-hmm. Any other questions? Yep. Mm-hmm. Yeah. Uh-huh. Super easy. So you just disconnect the tube from the cannula and you block it off with the little plastic and then you go swimming. So if you wanted to take a shower, go swimming, then you just disconnect it, do your activity, and then connect the pump back up again. With this pump, you've got 3 extra doses. So let's say your swimming class lasted more than an hour. You would just give yourself an extra dose to get yourself back on to your level that you should be if you were off the pump for more than an hour. Or first thing in the morning, you can use the extra dose to get you on quickly and not have to wait for the dose to kick in. So, but this is like this is very sturdy. It's not going to fall off. And then if you need to, you just disconnect it and connect it as needed. Mm-hmm. What else? Any other questions about it? It doesn't, you could cover it if you want to, but there's a little plastic that comes in here and that comes in here. So you can just keep them every morning and then block them off that way. And so it's very easy to maintain that way. So again, it's all day delivery. So it gives you that continuous infusion of the medication. And then unlike levodopa, there's no interference with protein in your diet. So there's no need to plan around what you're going to eat or just wait to take all your protein at the end of the day, which is what we do with oral medicines. So it gives you a lot more freedom that way. And because it doesn't use the same little elevator, the troughs, even with Vyalev, which is the phospholevodopa subcutaneous bone, you still have a little bit of a trough with apomorphine because it doesn't use that transporter to get into the brain. You don't notice any interference with protein. Yes. If you're on, Sentiment. So it's 100% bioavailable. So all of the apomorphine will make it into the brain. So it's a much more efficient way to take the medication because it's not a prodrug that needs to turn into dopamine in the brain. So you get much more medicine. So, with all of your medicines, you always want to tell your doctor, if you've got any renal disease or anything like that. And remember, all of your PD medicines, although they make your motor symptoms of PD better, they make non-motor symptoms of PD worse. So it lowers your blood pressure, it can cause dizziness, which can cause falls, it can cause nausea, it can make you more constipated, it can make you compulsive, it can make you hallucinate. And so our job is to try to get that balance just right, that you are on medicines, that you're mobile, but not so much that every time you stand up, you're fainting, you're throwing up, and you're compulsively gambling and not sleeping. So that's why your doctors are conservative. And when you come into the office, if you say, I'm good, we're not going to change anything. But if you say, gosh, I can't go to my Rocksteady boxing class anymore because they moved it from 2 p.m. to 10 a.m. and I can't get ready by then I'm going to be more aggressive in changing your medicine so I can get you to your Rocksteady class in the morning and not have to wait until the afternoon to do your activities. And so again, don't drink alcohol as it causes more side effects. It makes you sleepy. So we always ask our patients, are you falling asleep at stop signs or stoplights? Don't operate, heavy machinery, which is most of our patients don't. And then the biggest problem with apomorphine is the orthostasis, so the low blood pressure and nausea. So if you have nausea and you've never been on a dopamine agonist before, like Pramipexole or Mirapex or Ropinirole or Requip or Nupro, then we're just going to do a really slow titration, and it can be done at your house. So it doesn't matter how slow it is. And then if you're orthostatic or have low blood pressure, then we increase the fluids in your diet. We add salt to your diet. And if we need to, we can add Midodrine or Florinef or Droxidopa to keep that blood pressure up so that you can tolerate higher doses of Parkinson's medicines. And so.
Up the pump only takes about 5 minutes. I like that it's discreet, so I don't have to explain to people what it is. It's very lightweight, and I'm able to wear it around my waist. I feel comfortable enough traveling with it and getting through the airports myself. I can forget about it a lot of the times. Sometimes I actually forget at night that I have it on. And my husband will say, aren't you going to take that off before bed?
So again, that's what we want. We want you to forget that you have Parkinson's disease and you're just off doing your thing. And we're going to divorce you from the 6 alarms on your phone. So that's our whole goal. And so then, of course, to get it approved in the United States, we have to do clinical trials and to show that this medicine is better than placebo. And so this drug was studied both in Europe and the United States. And like we said, it's been in Europe for the last 30 years. So lots of safety data. They're doing very well with it. And we're going to do fine with it here. And so what we did studies to show is, did one apomorphine, did it reduce off time in our patients compared to placebo? Did we have more better good on time without dyskinetic or involuntary movements? And overall, did the patient do better on the medication? And we found that in all 3 studies that they did. So there was a 12-week study, and then they had a 52-week extension. So at the 12 weeks, patients had 2.6 less hours of off time compared to 0.9 in the placebo infusion. And we can see that these improvements happen as early as week 1. So as soon as you start therapy, you start to see the improvement in both your off time and on time without troublesome dyskinesia. And that overall, patients felt better. So nearly 8 out of 10 people felt that their Parkinson's symptoms were much improved or better improved than they were at the beginning of the 12-week study. And then, like we said, this is to be used as subcutaneous. It's not an IV medicine. So as IV, you can get blood clots, which we don't want to have. The nausea that we talked about, the sleepiness, we talked about dizziness, falls, hallucinations. We talked about those sorts of things. So the only thing, so if you develop anemia, you want to tell your doctor about it because it could be an allergic reaction, so that we need to work that up. And then you can also see priapism in the use of apomorphine. And again, some patients will have an allergic reaction. So, and then some patients may develop an infection. So what we do, if you have a red spot around where you have the infusion, we just have you draw a circle around it. And if the redness is going past the circle, then that's an infection. We'll treat it with antibiotics. If it just stays within your circle, that's just an allergic reaction. It'll go away by itself. And you can develop some granulomas or some bumps. And that's just allergic reaction to the medication, and we'll just move it around and that will absorb with time. Again, that's why you want to use the pills first. And then once we have to use pills more than 5 times a day, then use a subcutaneous infusion. And again, the 12-week study, then we're looking at the open label safety data for 52 weeks also showed that you had reduced off time, increased good on time, and improvement in your Parkinson's symptoms. And then what we want to see is more green. So we want to see more green that's continuous, that's not in little chunks of 2 or 3 hours of on time like you do with the oral medications. That overall you have more good on time and more predictability in your day than you do with oral medications.
Off time during the day. I can count on being able to walk in and walk out of places. My mobility is definitely improved. I can count on the medicine working where it's supposed to. My husband and I enjoy longer walks together in the evenings. I feel like I have more control of my Parkinson's symptoms. I'm continuing to be active in my community. I'm really glad I tried it. It has worked very well for me.
So again, what we want to give you is more control. If we can give you control over your therapy, we can give you control over the disease. So with a pump, it's much easier to control. So if you swallow the Crexont and you develop dyskinesia, we have to wait 4 hours for that Crexont to be metabolized, for that dyskinesia, the wiggliness to go away. And with the pump, you're dyskinetic. I can turn the rate down or I can turn the pump off. And 20 minutes later, the dyskinesia is gone. If you're off, if you took a pill and it got stuck in the stomach and it hasn't traveled into the small intestine, but then you take another pill, now they're both stuck in the stomach and then they go into the small intestine. I can't push that pill forward, but with the pumps, I can use the extra dose button and give you an extra dose if I need it, because for whatever reason, or if you're on phospholipidopa, you had a cheeseburger or a steak for lunch, then I can overcome that protein with the extra dose. Or you've went to Rock City Boxing, I can add more medicine. So I have more control over your therapy and therefore your disease with a pump than I do with oral medicines. So there's 98 milligrams in a vial. So usually you won't need more than that in a day. But if you do, then we have patients who get extra cartons. So in the infusion study, they did have the possibility of running it 24 hours a day, which would be off label, but like Duopa, half of them run 24 hours a day and we just use extra medicine. What else? What other questions? And again, we looked at the long-term studies that we saw the same thing we saw at the 12 weeks, that they had less off time, increased good on time, and better overall Parkinson's control. And then the nice thing about ANAPCO is that you've got the circle of care. So that not only does the doctor have help, getting it approved by your insurance company, but you have help at home. And that if you wanted to do the titration at home, you can. So you don't have to come into the office every 3 to 5 days to titrate the dose. It can all be done in the comfort of your house, where the nurse comes in and educates you about the skin, about the pump, how to use it. And then if you have lots of nausea or low blood pressure, the titration can be done very slowly and let you get up to speed at your own rate, instead of having to travel to the doctor's office to have the titration done. So that's nice. And then the other thing that's nice is that there's also a patient ambassador program, so that you can talk to patients who are already on therapy, and they can tell you the good, the bad, and the ugly. Would they do it over again? Do they like about it? What don't they like about it? So it's always good for these therapies, whether it's a pump or DBS, to talk to somebody who's already on therapy to make sure that it's the right option for you. So again, more reliability and predictability in the day is what we're going to get with your pumps. So again, who's a pump patient? When the patients come in and they say, I don't know when my pill's going to kick in and how long it's going to last, that's a pump patient. And so, ask your doctor. And then that's what I encourage you to be more of an advocate for yourself and go into the doctor's office and complain. Don't be the nice PD patients. The reason why we went into movement disorders, go and say, if there's things that you want to do and that you're no longer able to do, let your doctor know about them so that they can change your medicine to make that a possibility. Because now we have very good therapies to allow you to do that. And then the circle care we talked about, and that you can have your titration done at home, which is very nice for the patients. And then talking to a patient ambassador, which I always think I encourage all of my patients to do that. And then what other questions or concerns do you have? Anything else? Yeah, so you can still have a glass of wine, but it's not, you don't want to chug a 6-pack. But you can still have quality of life. So with Crexont, you don't want to take your pill with alcohol because that slows down the absorption, but you could certainly take your Crexont and then have a glass of wine at dinner. The 280s. Yeah, it's 280s. So oh yeah, so that you're super, yeah, so you've got a ways to go. Yeah, so at twice a day, you could go to, are you on 1 or 2 capsules? Yeah, so you're on a teeny tiny dose. So you could go 1 capsule 3 times a day and then go from there. So 1 capsule 3 times a day should do quite well, and you may not need more for a long period of time. And then they would just slowly titrate it up to 2, up to 4 times a day. And then you would either do the 350s or do the pump. Yeah, so you're on a teeny tiny dose. Any other questions? No? Okay. Sure. Yeah, thank you for your time. Yeah, sure. Oh, with the pump? No, so the pump is just titrating your dose. So let's say you're still having a lot of end of wearing off, you would increase the dose on the pump, the base rate. Let's say you had a lot of dyskinesia. So no matter where I couldn't find a rate where you were on without dyskinesia, then I would consider DBS or deep brain stimulation so that you could take the medicine and we could take care of the dyskinetic movements. Or if you had a tremor, so some tremors are levodopa resistant. So no matter how high I go on the medication, the tremor's persistent, then DBS would be an option for those patients. But usually we can do quite well, especially if we started early on, and keeping you stable. It's just a matter of changing your base rate. But once you're stable, you sort of stay on that dose for a long period of time. Unlike the pills where we're constantly tweaking those pills and going up and down and changing them around and changing the timing of the medicines, because we can't buffer. You're losing your buffering ability as the disease progresses. So I think we think that if we start the medicines earlier, that we won't make these receptors as jittery, and there's not going to be as many motor fluctuations later on in those patients. So it's Crexont. So it's a long-acting form of levodopa. So it's like a new version of Rytary. Yeah, so it's the next version of Rytary. So ask your doctor about it. It's been out since November. Yeah. So for sure, probably your doctor has samples of it in the office by now. Yeah. Any other questions? Okay. Yep. Yeah. Uh-huh. Yep. It's the same medicine. Yeah. Yep. You could. Yeah. It's the same medicine. So it's carbidopa levodopa, just your yellow cinnamon just won't last as long, but you can use it just as, yes. Yes. You can use up your big bottle of cinnamon. Uh-huh. Uh-huh. So cinnamon just has a very short half-life. So it doesn't last as long, and Crexon is going to last longer. So you're going to get more on time per dose on Crexon versus cinnamon. It's the same medicine, carbidopa levodopa. And this is apomorphine. Yes. Well, so this is on its way to getting approved. Yeah. Uh-huh. Yeah. A and B. Yeah. So it's just a matter your doctor does the prior auth to get it approved by your insurance company. They're very common. So almost everybody has them. They just don't tell us about them. So usually how it starts, you feel a presence in the room, but when you look around, there's nobody there. Then you can see little spots or patterns in the carpet or drapes. They start to move around. They come like 3D, or you can start to see spots that then look like bugs in the grout and on the floor. And then they can be fully formed little people, children. I live in Arizona, so there's like cactus people. But usually they're there, and then unless you ask, the patient's not going to tell you about them. It can make it worse. So all of the medicines for Parkinson's will make hallucinations worse. And so if that happens, we can either lower the dose or change the type of medicine or add medicines like Seroquel or Nuplacid to get rid of the hallucinations. Yeah. Entacapone, yeah. Yeah, it inhibits, so apomorphine doesn't need it, but levodopa does. So entacapone blocks one of the enzymes that chews up levodopa before it gets into the brain. No, so razagiline works once it's in the brain. So entacapone before it gets into the brain, and then razagiline, once it turns into dopamine, it prevents the metabolism of dopamine. Whereas entacapone is a COMT inhibitor, so it doesn't metabolize levodopa. Yes. That's normal. So because razagiline came out 20 years ago, so we just got used to using it. And so everybody gets, and it was monotherapy. And then back in the day, we thought that maybe it could be neuroprotective, although that never panned out. But old habits die hard. And so we start people on razagiline because it's once a day, very little side effects, but not very potent. Yep. And that's fine. Yeah. Razagiline, yeah. Razagiline. Yeah, so the Adagio and Largo studies did not pan out. Yeah. So we thought that, yeah, we thought that might be possible, but then the further studies didn't show that it was disease modifying. So we can't say that it's disease modifying. So exercise will do more for you as far as disease modifying than any pill we can give you. Anything else? Yeah, so we're excited that we finally get the pumps. And so our patients look good on the pumps. And that it comes out of Medicare and B, so I don't have to like figure out how to pay for them. So I'm very happy about that too. Okay, well, thank you for your time.